First, we should do no harm. That means healthy lifestyle instruction from the get-go, intervention when patients are overweight or have abnormalities, and start with a lower risk antipsychotic or agent whenever we can. If side effects occur at that level, try to intensify level 1, go to maybe a lower risk agent if possible, and if not, then start a weight loss intervention. And if side effects persist, even though if you can't switch to a lower risk agent, or you have to go to a higher risk cardiometabolic agent, then make sure to really collaborate with an endocrinologist or pediatrician to reduce those side effects by treating them directly, that is weight, hyperlipidemia, and maybe even insulin resistance. But when we switch to a lower risk agent, we have to consider the potential for rebound phenomena. By definition, our understanding has it so far that weight gain is associated with an increased blockade of histamine and cholinergic receptors. When these are blocked, not only can you get more weight gain and maybe cardiometabolic side effects, but also there is a side effect of anxiolytic effects, sleep-inducing or sedating calming effects. If you now switch from the penes, olanzapine, quetiapine, chlorpromazine, clozapine, that all have quite tight blockade of the histaminergic and cholinergic receptor, and you go to the O's, that's risperidone, aripiprazole, ziprasidone, then you're switching from a tight anticholinergic, antihistaminergic drug to a lesser blocking agent. So if you do that too quickly, rather than doing a slow cross titration, then the previously blocked histaminergic and cholinergic receptors that afforded anxiolytic, sleep-inducing calming effects can actually now fire because they're liberated, they're hypersensitive, and endogenous acetylcholine and histamine hits them. And then you can get, paradoxically, in the first week or so, some pharmacodynamic side effects and rebound phenomena where patients can have rebound anxiety, insomnia, agitation, and even some restlessness. Similarly, when you're going from a full dopamine blocker, particularly the tighter dopamine blockers, risperidone and first-generation antipsychotics, to a partial agonist or a looser binding agent like quetiapine, but particularly aripiprazole, then again these upregulated, tightly blocked dopamine receptors may get liberated if you switch too quickly, and endogenous dopamine hits them. And with a partial agonist, even the partial agonism can stimulate these receptors, and there can be a transient worsening of psychosis, mania, or aggression. So it's very important when you switch to a partial agonist not to switch abruptly, but to do what's called a plateau cross titration. So aripiprazole or quetiapine, clozapine would be added on to the existing antipsychotic that is either kept the same or lowered just by 25%. Then you're waiting until 5 half-lives have passed. That's 5 days with clozapine until you go up with clozapine, or maybe 3 days with quetiapine. But it's about 10 to 14 days with aripiprazole, and only then, when the full dopamine blockade has unfolded with these medications, would you reduce the initial pre-switch antipsychotic to avoid rebound phenomena. So this is displayed on this slide here. Abrupt switching can cause the most rebound phenomena. Even the traditional cross titration, as you're lowering the first antipsychotic while you're building up the second, can lead to rebound phenomena when the first agent blocks a receptor system much more tightly than the second, or when the first washes out quicker because of the shorter half-life, and the second one cannot keep up building up as quickly the same blockade. So a plateau cross titration on the far right here between the first agent in red and the new antipsychotic in green may be the better strategy, particularly when we're switching for weight reduction, when we're always going to a lesser antihistaminergic, anticholinergic drug, or one with partial agonism. If the switch or the healthy lifestyle intervention doesn't work, what are some treatments we can use for weight reduction? Metformin has been studied the most, and also in children and adolescents. For kids less than 40 kilograms, you could use 250 milligrams for 1 week with a meal, and then go to 250 twice a day, up to maybe 750 milligrams maximum. More than 40 kilograms, you can go up to 500 milligrams for a week, and then go to 1,000 and 1,500, maybe even 2,000 milligrams divided in 2 doses and giving it with meals. Kids have no risk for lactic acidosis, and usually there's also no glycemia because it's not lowering glucose levels itself, but rather sensitizing insulin receptors. Orlistat is another medication that has been used and is actually approved for weight loss. Metformin is not approved for weight loss in kids, it's only approved for diabetes. Orlistat approved for weight loss in obese kids, up to 120 milligrams TID. Very important to give it with a low-fat diet, because otherwise the lipase inhibition can cause very fat-rich stool, which can lead to diarrhea or even encopresis during the day. Amantadine and topiramate, amantadine and bupropion have not shown good results. Topiramate has a good signal for weight reduction, but it can cause also sedation and word-finding difficulties, so it should be tried rather carefully. And the other agents to reduce hypertension or dyslipidemia most likely should be prescribed by a pediatrician. So in summary then, psychostimulants, antidepressants, antiepileptics, lithium, and antipsychotics have varying levels of proven efficacy in youth with either aggressive spectrum disorders, schizophrenia, or bipolar disorder. As a side, I haven't shown these results. Mood stabilizers do not seem to have a very large effect size when it comes to aggression, but antipsychotics have a larger signal, as I've shown you the data. But even in mania, there seems to be a somewhat reduced efficacy signal, at least based on the few studies we have in kids. Stimulants can cause a decrease in body weight and growth, but that's dose-related and seems to level off over time, and also is reversible largely when medications are stopped. Antidepressants and antiepileptics are helpful for either depression or mania, but they have a low but increased rate of suicidal ideation or behavior, particularly in younger kids, so we need to monitor for that. Youth are at higher risk than adults for extrapyramidal symptoms, prolactin elevation, sedation, weight gain, as well as lipid abnormalities. And although diabetes and metabolic syndrome are rather rare early on in treatment or in the shorter term trials that we have seen so far, the concern is there that this could happen over time because there is significant weight gain with many of these medications. So what are the recommendations? Patients and families should be included in a careful risk-benefit evaluation when choosing specific psychotropic medications. We should carefully set the indication whether a medication is even needed. Always have also psychosocial interventions at hand, because medications alone are usually less effective than with psychosocial interventions, and particularly for aggression, many of us believe that no psychiatric medication should be started unless psychosocial interventions have been tried first. When we give these medications, there should be a clear routine and proactive monitoring of side effects, as shown on one of the slides, in order to make sure that we pick up on the signal if patients actually develop these side effects early. In case of severe early side effects, consider switching to a lower risk medication. Early changes, particularly weight change, predicts later change, so it's basically an intra-treatment litmus test for this particular medication and this particular patient. Mechanisms and risk or protective factors for specific adverse effects clearly deserve further study, and we need to also test more interventions to reverse or even prevent specific adverse effects in our youngsters that unfortunately require these medications, often long-term, for severe psychiatric disorders. Thank you very much for your attention. I hope that this was helpful for your clinical treatment, and if there are any questions, here's also my email address. I'm happy to answer anything if you send me an email. Thank you very much.